Rebecca and I are bioengineers, and we've been long involved in developing medical technologies and teaching students to do the same. And we co-lead an organization called Nest 360, which is a consortium of 17 organizations, 13 of which are in Africa. And this consortium is laser focused on ending preventable newborn deaths in hospitals. And this group represents what you would expect, which would be clinicians, but also biomedical engineers and technicians, commercial entities such as local and global distributors and implementation researchers. And Nest 360 aims to be an end-to-end solution, like was described before, where we're looking at all of the barriers that are in place that keep us from ending preventable newborn deaths. And I wanted to start by just talking about where we started way back in 2006 and 2007, when Rebecca and I visited hospitals and went into newborn wards and saw the fact that there were just amazing clinicians that didn't have the tools they needed to be able to give the care they wanted to give to babies. And as moms, of course, that is just simply heartbreaking. At the same time, we were taken down the hall and went to what was referred to earlier as an equipment graveyard. As engineers, that equipment graveyard is also heartbreaking, because what that represents is technologies that have been put in place, but maybe they're not the right technology for the right use. Perhaps they're not rugged enough, or perhaps there aren't biomedical technicians to repair that equipment, or a good local supply of spare parts and consumables for that equipment. So when you couple these two things, the babies that desperately needed, for example, access to oxygen concentrators, and oxygen concentrators sitting idle and unused and broken in the equipment graveyard, we knew we had to work together with our local partners to solve this problem. And at the surface, in terms of thinking about the equipment itself, we know we need biomedical technicians, but we also need biomedical engineers, local biomedical engineers, to invent and qualify rugged technologies for use in this environment. And at Nest 360, we're doing both of these things. The team is developing and has developed education materials and courses, skills labs for pre-service training, but also for in-service training of biomedical engineering technicians. We're working in 4 countries right now: Malawi, Tanzania, Kenya, and Nigeria. Soon we'll be working even more in Ethiopia. One activity that we have undertaken with UNICEF that we have found to be really impactful is that we've developed with a group of clinicians and technicians and industry partners and UNICEF target product profiles. And what these target product profiles are is the specific need within a particular technology. So what exactly are the specifications that a particular technology might need to meet? And having a listing of these and having them publicly available on the UNICEF website has signaled to manufacturers what is needed, and innovators, what is needed for these particular products. And then we've worked to look around and landscape existing technologies and bring them into the lab and test them to see, do they meet the specifications and do they meet these target product profiles? And by creating a list of what we find are rugged and effective and highly usable technologies, that helps others when they're making decisions about what to purchase. For biomedical engineers, we've started invention education efforts at universities, which include design studios, where students and faculty can go in and create solutions to locally identified problems. Some of the inventions that have been worked on at these design studios include, for example, something we call Lucia, which is a cervical cancer screening and treatment training system where nurses and clinicians can practice techniques, for example, for identifying surgical or cervical cancers and lesions. CPAP device has been developed. During COVID, the design studios were able to respond in an amazing way where when supply chains weren't available. For example, the design studio in Malawi created 80,000 face masks to be able to protect the local healthcare workers. They developed hand washing stations and sterilization rooms, all just local solutions to problems that were happening locally. They were able to jump in and solve these problems. One of the questions we were asked to address is how might some of these efforts be scaled in partnership with the private sector? And one of the ways we've worked with the private sector is was mentioned earlier about supply chains and thinking about how do we, particularly for our situation, how do we get newborn technologies to be available and sold locally in these in the countries where we're working. And that has looked like creating a global distribution system that's nonprofit that works with local distributors or local businesses to ensure that when some of these products are sold, that there's an actual representative on the ground to uphold the warranties, for example, to make the repairs, to make sure that the consumables are available, all of those kinds of things. And we feel very strongly that business and market work is absolutely critical to the long-term sustainability. And we can imagine that thinking about when we, for example, install new equipment, make sure that there have been adequate training, not only for the clinicians, but for the biomedical technicians, and that be built into the cost of the equipment that is sold. We think the private sector could invest in skills labs, in faculty development workshops for trainers of biomedical technicians, as well as the technicians. And, I just would say that from our work, it's been absolutely critical that when you're tackling a clinical medical issue, that you also have to tackle whatever technology issues are associated with getting the technology placed and put in the facilities, and making sure that the clinical team knows who the biomedical engineers are at the hospital and who to call. So the thing I'll end with is one of our, I would say, most successful trainings has been when we bring the clinicians and biomedical technicians together for the trainings so that the technicians understand why is this equipment so important, and the clinicians understand who to call when a piece of equipment breaks. Rebecca, what have I missed in this quick summary of our work?
I just wanted to add two things. One is that we have developed a monitor for any piece of equipment that plugs into mains power, and there is a dashboard that can monitor when the power is on or off, when the piece of equipment is on or off. So we can actually look on a dashboard, and the biomedical engineers within the Ministry of Health can also look on the dashboard to tell, is equipment being used? And if it's not, that can trigger an intervention to see if it needs to be repaired. And with that, we've been able to keep over 99% uptime of the equipment that has been provided for newborn survival. And the second thing that I'll add is that just like biomedical engineering in the United States, we see that there are a lot of women students that are really attracted to the opportunity to study a field of engineering that has such a strong impact on health. And we're seeing the same thing at the African universities with whom we're collaborating. Thank you.
Actually, I wanted to raise a question even before, but I think you've answered part of my question, because as we look at what David told us about the biomedical engineering problem, so I was thinking like among the things that we need to do is to get, the equipment, deliver the equipment, put the equipment in the hospitals. But I was worried about what happens afterwards. And one of the things that we know is that, as said earlier as well, when the equipment is there, if there is no maintenance for the equipment, then we are lost. But the other part is that we need to have the people that know how to do that. And that the people at the hospitals need to know who to talk to and to actually negotiate at the moment, even if it's a donation, at the moment of receiving it, that all these aspects are considered. Because this is super important. Otherwise, we actually continue in a circuit that we will never improve this. But my other question was, like, if you actually are able to deliver equipment, as you say, like something that is not used, that you actually make it feasible to be used again, what happens when technology evolves? I mean, is your project ready to actually support those who you are supporting to move within the platform that you're working on the technology, but to a new equipment, to a new device, or something like that? That was one question. And the second question was a little bit for the three of you. It was, and for all the audience, because we've heard about equipment, financing, rural areas, everything that we need there. But what we need in the rural areas as well are all the medics, the medical people, the physicians, the nurses, and everybody that has to give the service. And I wonder, I mean, at least from my experience in the countries that I've visited, the further you are from a big city, the less likely you are to keep the trained personnel, that you invest a lot of time, and they are very keen on continue doing this, to be there for a longer period. So what are the strategies that you've used to actually maintain? For instance, let's say you get to have a gynecologist very specialized in doing this type of surgery. How do you keep that person that far away for a longer period?
Yes, go ahead. They were running out of batteries, but.
Thank you. Thank you for that question. Yes. So the policy that I said, which is a framework that helps the investment, whether from government or private sector or donors, is comprehensive in that it actually looks at all the building blocks of the health system. Human resources being the key pillar. Now, the strategies that we can use or are using again, I'll use the Republic of Zambia. Some of these things are measures that government is already working on to implement. We know, and it's true, that in the rural areas, meeting the doctor is difficult, especially a specialized one. But government has a plan that we want these kind of services to be provided at the district hospital, meaning that we need to have those that can actually diagnose, be able to take the tissue diagnosis, if, for example, if it's cancer, or even manage these cases at the district hospital, because that's the closest we should do that. This also it supports the primary healthcare, levels, the clinics, the rural health facilities going down. Now, yes, of course, what's the challenge? The first challenge, obviously, that government has to deal with is dealing with the establishment. Government is working to open up because the establishment basically says the structure of that facility. There are specific staff members or people that should be at a particular facility. We know that in the past this has not been possible, was not done, and so it couldn't allow government to position these trained staff in those areas, because then we'll have to take a surgeon and put him in a junior position in a district hospital, which doesn't really work well. Okay, that's one. Now, the establishment, it's unlocked, and the minister, I think, has already been speaking to. Today, our Minister of Health has been talking about redistributing human resources or trained healthcare workers within the country, because most of them are concentrated in the big cities. And of course, like I said, issues of establishment, and that's what has come from the medical fraternity themselves. They are willing and very able to go and work there because they themselves have also realized other benefits that are in the rural areas. In the city, we struggle with space. Everybody wants land, businesses. In the rural areas, those opportunities are immense. And the doctors already know this because they've been working, and so they are keen to go. But those things needed to be put in place so that they can go actually work in a position that is appropriate for them. But of course, there are other issues that they may need. Issues of schools for their children, issues of power supply. And as government has a big component of renewable energy to electrify the rural areas with solar energy, and we have unlimited solar energy in our country. Those things are going to stabilize the other needs of power. And of course, the government is also investing heavily in infrastructure. Roads to these rural areas that could be accessible, ensuring placement of other banking and other things that the people in the rural areas may need. And obviously these again are going to make the rural areas much more desirable for the people to work in those facilities. So it's the policy. The policy is being revised to allow for inclusion and placement of specialized health workers in the rural areas. And of course, there will be other things that are going with it that are not really coming from the health sector, so to say. Like I said, there is education issues, there is energy issues, and government systematically is doing in those areas. But of course, government cannot work alone. The country is big, the needs are many, and that's why donors and partners are needed. And we're not talking about just investment in health. There should be other donors that can deal with us on the energy part, not only for the hospitals, like he has said, but there's energy for schools. The energy for households, So that's how we're approaching it. It's a systematic thing that needs to be done. Government at least has the commitment. Government has made the effort and is making steps towards that. And that's why we're here. I mean, if we're not committed and we're not interested, we wouldn't be sitting at this table discussing this. But thank you for raising that issue.
And I think we take on the challenge, as we had said earlier, and we just been discussing it with Dr. Ted and Dr. Key, and I'll let them comment, but it's kind of like a football team, right? So you're going to need different partners at the table, the investments, the technical partners, the supply chain management. So let's take it as, potential.
Just a quick add-on. In terms of, because again, we have done studies on the health workers to find out when they leave the rural areas, because they've been placed there before, why do you want to leave? What would you want, for example? The things that they want usually sometimes is that, they want more money, but what do you want to do with the money if we give you the money? They say they want to buy land, they want maybe vehicles, stable, better vehicles. Government owns land. Government can make land available to these health workers in those specific areas and create a mechanism where they don't have to pay us upfront. They can pay in 60 years. So they are tied down to that particular area. Government can procure vehicles that may need me, because sometimes the rural area you may need 4x4 vehicles. Government can procure 4x4 vehicles and give these health workers and give them to pay back over a long time. So government has mechanisms that they can use land, they can give land to these health workers so that they, like I said, they can build their house or they can have their farm and then they can pay back slowly. But that helps with the retention, because these are the things that they want money for. They want money so they can buy land. They want money maybe so they can have mobility. And government has access to these things and can provide those resources. So we have options as a government.
Thanks, Emmanuel.